Please start the session.
Yes, thank you. Thank you, Smita. First of all, I welcome all of you to this today's webinar on iron neuro ophthalmology subsection. Today's session will be hosted by SMS Jaipur with the panelists, with the moderators being Professor K.L. Kumawat and chair coordinator, site coordinator being Professor Bhavna Sharma. The SMS Jaipur is presenting a series of very interesting case and a journal club based on the imaging biomarkers in optic neuritis. We will start with the journal club, which will be conducted by Dr. Aditi Jain. So over to you, Dr. Kumawat and Dr. Aditi. Please carry on.
Thank you, Dr. Karthik, and I welcome you all on the platform of IN. Dr. Bhavna, Senior Professor and Next Surgery HOD of SMS is with me, and our residents, Dr. Adhiraj, Dr. Vipul, and Dr. Aditi is there. Because of some technical issues, we will start first Journal Club, and then we will discuss the case. So Dr. Aditi is Senior Resident, and she is very intelligent fellow with us. Now, Dr. Aditi, I request you to start the Journal Club.
Okay, thank you, sir. First, I will share my screen with all of you. Good evening, everyone. Is my screen is visible?
Yeah, it is visual.
Thank you so much, Dr. B.L. Kumawat sir and Dr. Bhavna Sharma ma'am, to giving me this golden opportunity to present a journal in this under the academic activities in Indian Academy of Neurology. Today, I would like to discuss the imaging biomarkers in optic neuritis. The article where I would like to discuss was published in 2025 in Frontier of Neurology. So the three modalities I would like to focus on in this journal is the OCT angio, and MRI DTI. How we can use these modalities for early diagnosis of optic neuritis, for the prognosis and for the treatment of optic neuritis. So first, as we all know, optical coherescence tomography, it provides the micron level structural measurements of RNFL and GC-IPL layers. The OCT angio is for non-invasive dye-free mapping of retinal microvascular density and perfusion matrix, and the DTI for the deep demyelination and axonal damage. So in OCT, we measure these two layers, the retinal nerve fiber layer and the ganglionic cell inner plexiform layer. So the retinal nerve fiber layer is a marker of axonal loss, and GC-IPL is a marker of neuronal loss. As we all know, there was a progressive physiological loss of 0.017% per year. But after an attack of optic neuritis, the average reduction is about 15 to 18 micrometer in acute episodes. As in GC-IPL, that was stronger correlation with visual dysfunction, and thinning occur more earlier as compared to RNFL. The OCT can be used to see the dynamic changes in the different layers of the retina, and that can be used as a marker of further progression or further prognosis of visual acuity and axonal loss. So in acute phase, we all know that initially RNFL thickening due to edema marks the underlying axonal loss. So that thickening differ in different diseases. After 2 to 4 weeks, the GC-IPL begins to thin significantly, providing an early signal for neuronal damage. After 6 months, if these structural damage is stabilized, it's suggestive that there was a permanent axonal loss was occurred. So we can use this OCT as a marker for no evidence of disease activity, because if the retinal thickness is progressively decreasing, it's suggestive that there is an ongoing neurodegeneration was going in the brain. So the most commonly studied OCT in MS. So in MS, the retinal nerve fiber layer thinning evident after 3 months. So how we can use it as early as possible? So while the GC-IPL thinning, that is an earlier and more specific marker for neuroaxonal degeneration. There is a specific pattern of this thinning in OCT in MS, that temporal RNFL thinning suggestive of MS pathology. The inter-eye asymmetry is more useful as compared to single eye findings, because if there is a 4 micrometer difference in GCIPL layer between two eyes that can be used for detection of that patient has prior optic neuritis attack. So, in MS patients without any clinical optic neuritis may still show the thinning due to the subclinical optic nerve involvement and diffuse CNS neurodegeneration. As I already told you, that can be used as a NEDA marker. But a drawback of OCT is that if a patient is having recurrent optic neuritis, the retinal nerve fiber layer thickness rarely falls below 30 micrometer. So in late stages, we cannot use this OCT as a prognostic marker. So as I already told, OCT is not only for to use for the prognosis purpose, it can classify the diseases also. On the basis of OCT, we can say if there is a focal temporal thinning, it may suggestive that patient may have a MS optic neuritis, as we can see in this OCT. If the NMOSD is having a devastating result on the retinal nerve fiber or GCIPL layer, there was a severe and diffuse loss across all the quadrants, and reduction is approximately 28 micrometer in a single attack of optic neuritis. So the visual recovery chances are less in NMOSD. In MOGAD patient, we see the thickening of RNFL layer, but often after the thickening, patient has a severe vision loss, but the recovery is good. So in OCTs in MOGAD, that was seen like there is less thinning in further attacks. So how we can use this OCT in a first attack? It was a study that suggests the how we can differentiate MOGAD with NMOSD in optic neuritis patient. In MOGAD attack, the RNFL thickening is very much. It's around 157 micrometer in a study of 111 patient in 83 MOGAD patient. So they use this as a cutoff. They suggest that if there is a thickening of more than 115 micrometer in a first attack of optic neuritis, it may be suggested that patient is more likely to have a MOGAD episode rather than NMOSD episode. Then the second modality I would like to discuss is OCT angiography. As I already told, it is a non-invasive dye-free imaging modality. It uses the blood flow motion contrast technology to create an image. It creates an image of the superficial capillary plexus. So we can use it to quantify vessel density around the peripapillary or perimacular layers and in the perfusion parameters. It is a very rapid, safe, and repeatable procedure. So we can see in this picture, the upper two pictures showing upper two images showing that patient is having an attack of optic neuritis, and lower one patient is not having the normal eye. So we can see the color coding, the blue suggestive of more loss of vessel density and reddish towards the more vessel level. So after the attack, the blue is discoloration showing that the vessel density decreases in NMOSD attack and MS attack. So same as OCT angio is also having a different pattern in different diseases. In NMOSD, there is more than 20% reduction and significant larger foveal avascular zone. In MS, there is a milder vascular changes. Primarily, as in OCT, we can see the temporal loss. In OCT angio, we also see a temporal loss. In MOGAD, there was near normal vessel density levels. So the third modality I would like to discuss is diffusion tensor imaging. It is a very sensitive MRI technique for assessing the optic nerve microstructures. It detects the axonal injury and demyelination before the structural atrophy develops. So it provides a quantitative biomarker for optic nerve integrity. So in DTI, we use these parameters like fraction and isometry disproportionate to the myelin destruction. It proportionate to the intact myelin. So the highest the FA level, the lowest the axonal damage. The diffusion coefficient is proportionate to injury, edema, and inflammation. So higher the diffusion coefficient, the higher the inflammation and destruction of the axons. So with these fraction and isometry and radial diffusibility, we can see more optic nerve damage in optic neuritis. So in DTI, there are in NMOSD, we see it is a very destructive and very severe disease. There is a very reduced FA and increased RD. In MOGAD, very severe DTI changes, but the axonal preserve less severe DTI changes. So axons are relatively preserved. In MS, there was a focal changes. So DTI is an early can use as an early prognostic tool because before the MRI changes in T2 and FLAIR, we can see MRI changes. It appears earlier, and we can detect the optic neuritis earlier through the DTI images. But it is not commonly used to detect optic neuritis in present scenarios due to some limitations. There is a small size of optic nerve makes imaging technical challenging. There is a motion artifact from the eye movement. There is a variability between scanners and acquisition protocols. It is a very time consuming and lack of standardizing normative value. Maybe the future will be future in future it will improve and it give a more earlier diagnosis of optic neuritis. So, one brief about what changes in optic neuritis we see in pediatric and adult population. Pediatric population, as we all know, MOGAD is more prevalent as compared to MS and NMOSD. Then acute attack, there was a severe swelling in RNFL layer as compared to adult in pediatric population. But in prognosis, we see the higher recovery potentials and a less atrophy or less thinning in further layers. Through the OCT, we can see this. So, last, I would like to say the future of these markers that we can use these complicated cascades, cytokine loads, or axonal debris for the future for the diagnosis of earlier detection of these diseases, like the complicated cascade C3A C5A correlate with the greater thinning. So we can use this if there is a higher level of C3A C5A, there is maybe a poorer visual recovery. In IL-6 TNF alpha correlate with the microvascular rarefaction or decreased vascular densities, and this serum neurofilament light chain is proportionate to the acute structural damage. So more the damage, more the serum NFL levels. So maybe in future we can use these markers for the diagnosis of these demyelinating diseases. Thank you. Thank you so much.
Thank you, Aditi. Well, you have discussed well. Dr. Adhiraj, are you ready?
Yes. Meanwhile, we can have some questions from the audience if somebody has some questions regarding the biomarkers in optic neuritis. We have with us Dr. Astha. She has a lot of experience in OCT RNFL and the use of it in optic neuritis. I don't think any neurologist has so much exposure to OCT RNFL than Dr. Astha, ma'am. Ma'am, are you available now?
Yes, thank you. Thank you, Karthik. I'm there. Thank you for the beautiful presentation. I think she covered a lot. She covered a lot also about the other biomarkers, which is a very good thing because actually this is the current domain of a multi-omic approach. So only one thing I would want to ask you is that were you able to find distinct differentiation between MS, NMO, and MOG based upon OCT, RNFL, and GCL studies? One. And secondly, what about the qualitative assessment of the OCT? So maybe these 2 points, in case you can highlight, it will be good for our younger colleagues.
Dr. Aditi?
Yes, sir. As ma'am, in our hospital, we routinely do the OCT studies in different demyelinating disorders like in MS, NMO, and MOGAD. And yes, ma'am, in acute attacks, we found the RNFL thickening was there, but we are not so sure about the thinning levels, because in first attack there was edema in the layers, so we cannot comment on the differentials of the disease. But after in follow-up studies, we have found in our patients, and there was one thesis also going on in our department by my colleague also in OCT, continuous OCT monitoring, ma'am, in 3 months, 6 months, 9 months, and 12 months. The more we can use OCT in a prognosis or in a disease in a disease के जो पूरा pathway है कि pathophysiology में we can more use OCT as compared to first attack. So yes, ma'am, we are using it in our department also, and we are able to see it, the changes. Typical in MS, progressive thinning, we are able to see if patient is not responding to any treatment, ma'am.
Yes, thank you. Thank you, Aditi. Just to add on, so in case there is at presentation, in case there is more than 15 micron meter difference in the inter eye, So that points out more towards a catastrophic loss in one eye as compared to other,
Okay.
which may suggest
Okay.
a NMO MOG-like pathology as compared to a MS-like pathology. And secondly, in case your clinical picture is not matching, it is nice to do a qualitative assessment of the retinal layers, which can show you any macular edema, any serious retinopathy, and help you see if there are other causes of vision loss in a given patient also.
Okay. Thank you, ma'am.
Thank you, Dr.
Yes.
Atta. I think Dr. Adhiraj has made the screen visible. So we can start with the case. Dr. Adhiraj is
Uh,
a senior resident third year in Department of Neurology. And are you ready, Dr. Adhiraj?
yes, sir. Thank you for the opportunity, sir, and thank you for your patience. I will now start the case presentation that we have selected for this webinar. Um, just a minute, I'll just share the screen. And,
Okay, it's visible. Now you can start.
yes, sir. So, the case that we have taken up today, sir, is the case of proptosis and ataxia in a young male, which helped us to lead to a conclusion of a rare disorder. So, starting with the basics of the patient. So, our patient was who came to us was a 26-year-old male. He is a postgraduate, right-handed, coming from the Lalsot region within Dosa. He came to us with three major complaints, which he presented to us with. So, firstly, he said that since past 5 years, he's having multiple light-colored patches over his skin, starting from his face and then moving on to the rest of his body. Then he said that both of his eyes appear to be bulged, and lastly, he says that he is having some difficulty in walking since past 2 years. Now I'll elaborate on these symptoms that which we gained from the patient when cross taking his history. He says that he has two lesions on his skin. One predominantly, which he says that he has multiple small, uh, light colored patches starting from his forehead, which then moved on to his neck, then his chest and abdomen. These lesions gradually progressed, were not painful, not itchy, and there was no any scaling on these lesions. Additionally, at around the same time, he noticed that he had some small raised lesions, which he found to be slightly painful on touching, and he felt that there was a lot of crusting on these lesions. And for these two complaints, he consulted many dermatologists, and who eventually told him that he has some form of skin allergy with some added infection which is causing all these issues. He took some medications. There was some partial improvement, but never a complete or a definite resolution. Then the second symptom that he developed was around 2.5 years ago. He started noticing that his left eye, when he looked in the mirror, it seemed to be bigger than the right eye. And okay, initially he ignored it, but then his family members also started noticing this. And then a couple of months later, he saw that the right eye is also looking a little bigger than it used to look. And this bulging of his eyes has since past 3 years has gradually increased, but has still of yet remained asymmetric, such that the left eye is more prominent than the right eye. During this entire 3 year episode, he never developed any significant decrease in his vision or any pain in his eye or any fluctuation of these symptoms, any excessive redness, watering of these eyes. But he did develop a double vision. This doubling of vision, he said that initially when it happened, when he used to look towards the left side, and that also for distant objects. But then as time went by, he saw that even when he used to look straight, the same symptoms happened, and then he used to look towards the right, then those symptoms also started happening. He said that these vision, the doubling was almost completely side to side, with the unclearer image being on the left side. And then he developed a different form of symptom around 2 years ago. When while walking, his family members started laughing at him and saying that why has he drunk? But he used to always say that he has had no habits and he never drunk. But then a few months later, he also started feeling that there is some instability while walking, and he used to tend to sway to either side. and used to tend to take support of nearby objects to stabilize himself. Then around 1 year ago, he felt that while walking and standing up or doing any motion with his legs, both his lower limbs became tight and he could not move them as freely as he could earlier. Then the next two symptoms that he developed was about 8 months ago, and another happened 6 months ago. The 8 months ago, he started saying that there is some form of loss of sensation in his bilateral lower limbs, which he described as numbness. And this numbness, which he says, was initially localized to both his lower limb soles, and then he felt that it has gone up all the way to his knees. Then around 6 months ago, he started noticing that his hand started also shaking, and especially when he used to try to eat or hold a pen while writing his exam, and because of which his handwriting also became to be clumsy and he could not write properly. Then most recently, he developed an additional issue in which he said that since past 3 months, he's having difficulty in while passing urine, such that when he goes, he is unable to void it completely. He stands there near the bathroom and near the WC and tends to exert, and then after some time he manages to pass the urine. Then also simultaneously says that these urinary symptoms develop very suddenly, suggestive of there is some element of urgency and hesitancy as well. Along with that, his family members have noticed that he is not able to concentrate as well while studying, and says that there is some problem in focusing and remembering of things. To understand the case more, we took some more history for the patient, and we found that he has no history of any significant weight loss or appetite, long-standing fever, or any joint pain or swelling. He does not have any nasal symptoms, and he does not have any pain abdomen, any history of recurrent bleeding, or any jaundice. No history of increased thirst or any intolerance to cold or any symptoms of loss of sensation or weakness in the upper limbs. He does not have any history of any chronic long-standing headache or neck pain as well. Lastly, when we took further history about birth, developmental, family, personal, we did not find any additional findings. So now at this point, I would try to understand and localize these symptoms and try to gain some sense of what is happening with the patient. Firstly, the patient that he says that he has some amount is regarding his proptosis. The proptosis, as we can see, can come from multiple sides. It can be per se because of the extraocular muscle involvement, or the or an intraorbital involvement, retroorbital extension, or coming from the osseous bones. For our patient, it seemed that either the extraocular involvement was what we suspected to be more likely, with some possibility of an orbital involvement, suggestive that it could be a large series of diagnoses which affected this condition, such as maybe a Graves' orbitopathy, or sarcoidosis, or a bony tumor, or as well as any lymphoma, or other cranial tumors such as lymphoma, meningiomas, or neurofibroma, name a few. There's a long list for this. So then moving on, regarding his diplopia, our understanding was that initially it seemed that the left lateral rectus was involved, but as time went by, other muscles also got gradually involved, such as the left medial rectus, or possibly the left superior oblique as well. And lastly, moving on to the right lateral rectus. Then for his neurological symptoms, we had multiple localization. His imbalance that he initially complained, along with his tremulousness in his hands and his erratic speech defect, it seemed that there is involvement of not only the cerebral hemisphere, but possibly the dento-rubrate thalamic tract, or the cerebral peduncles may also be involved. Then for his numbness, it localized to the spinothalamic tract, and for his stiffness to the pyramidal tract. And because we say that with the onset of this numbness, his symptoms of imbalance drastically worsened, where the patient was initially completely independent, now needed one person's support to even sometimes stand up, we felt that the posterior column may also be affected in this patient. So possibly there's an additional component of sensory imbalance. Poor concentration, we are localized to the frontal and the fronto-subcortical circuits. And for his bladder symptoms, for urgency, we localize predominantly to the pontine and the frontal micturating sepals, whereas the urgency we localize to the uh, conus, to the conus and the spinal localization. So eventually, I will summarize this case at present, such as that the patient is a 26-year-old male who has come to it with a progressive multisystemic disorder affecting the skin, eyes, and nerves. Three system involvement we have found, and at present in ambulatory, he requires one person support for all ambulatory purposes. At this point, I will now move on to the examination part of the presentation, sir. Permission.
Dr. Adhiraj,
Yes, sir.
Dr. J.M.K. Murthy sir is with us. I can see him in as a participant list. Sir, can you enlighten us that on the basis of skin lesions, ataxia, bladder involvement, and proptosis, at this stage, on the basis of history, can we make some diagnosis? Uh, Dr. J.M.K. Murthy sir, are you audible to me?
I think Sarin can type in the answers in the chat box. We can see even in this one.
Okay, so any input from other participants at this level?
Yes.
That on the basis of history part, can we make some diagnosis?
I think we can encourage the residents to think of think of their answers and some possibilities. Meanwhile,
And they can put in the chat box. Okay.
Yes, you can put it. Meanwhile, we have Professor Vivek Lal also, sir, with us.
Yes, sir.
Sir, you want to comment something about this case, sir?
No. I actually am sitting back and reminded of my residency days when actually I knew nothing when a case was presented. Beautiful presentation. All I can say is all I'm seeing is there are no seizures. Again, same way I discuss. Think aloud. There are no seizures. There is no headache. And it appears to be a multi-system pathology. Now, I don't know what the skin lesions are. Whether you're looking at proptosis means a mechanical disorder. Proptosis means that the eyeballs are coming out because of pressure from behind. So one thing is very clear: it is not a medical but a surgical disorder where you have got soles all over the brain which are producing this kind of a picture. And now what is important is you have to integrate the skin lesions with all that you are seeing. So I don't know what the skin lesions are, to be very honest. We have not been told about the skin lesions. We have not been shown the skin lesions, and we don't have the dermatologist's opinion. But there is definitely, from what Adiraj is saying, the clue to what this patient has lies in the skin lesions, right? So whether it is some kind of a diffuse histiocytosis, some kind of a lymphomatous involvement, these are some of the possibilities. You have cerebellar involvement, it is very obvious. It is progressive cerebellar involvement. You have got bladder involvement, means there is spinal cord involvement. It means that there is a lesion which is also compressing the spinal cord. It also tells us that this lesion is multi-axial. It is not along one plane, it is multi-axial. So you're having a multi-axial lesion. You're having a lesion which in all probability has got manifestations ramifying beyond the nervous system and reaching the skin. Skin, as we all know, when it comes to its embryonic origin, originates from the same layers as the nervous system does. So often you may get a lesion where the nervous system and the skin are involved in tandem, right? So ectoderm, if I'm not wrong. So this is how I would look at it. This is something that is combined and involving both these organs. Organs are tissues. That's my take. I can't go beyond this. Whether it's a neurofibroma or whether it is XYZ, I can't say. It's impossible for me to go beyond this. It's a blinder of a case, and I congratulate you for picking up this case. In fact, I wanted to congratulate you for the first journal club also, but I thought I will do that at the end because I don't want any interruption with this case. That's my take on this case.
Thank you,
Thank you,
sir,
sir.
for your
Thank
valuable
you, sir. So, Dr. Adiraj, I think you could continue with the examination part.
Yes, sir. So now moving on to the examination. We'll try to get some clarity on our issues that we have faced with the patient. So the general examination did not reveal any additional findings. The vitals of the patient were stable. There was no pallor, ectocyanosis, clubbing, or lymphadenopathy. So these are the skin lesions that we were looking at. So I would describe these lesions as multiple, hypopigmented, macular lesions, varying of varying sizes, but remaining within the macular size, uh, existing on the forehead, the neck, the trunk, both the chest and chest, abdomen, and back. Additionally, what I can also appreciate here is that there are some xanthelasmic changes also present over both eyes. And then we saw the scalp. In the scalp, we found these lesions. When the patient came to us, he had only 3 or 4 of these lesions. So we were not able to appreciate them at their more ferocity. But it seemed that the lesions appeared to be definitely tender. There was an erythematous base, and there was severe orange to brown crusting on them. This was what we saw. Then, continuing with the examination, what we see is that the patient has bilateral proptosis, and here we can see the patient's on the left side, the proptosed eye is much more than on the right side and with the front of the eye. And even now, after 2.5 years of the history, we can appreciate there's only some minor amount of chemosis is there in the left eye. Otherwise, the eye otherwise appears to be normal. There is no edema. There is no lid lag. Some retraction may be seen on the left side, but other than that and the proptosis, the eye appears on both sides to be does not reveal any additional findings. And
One
then
second, go back. Adiraj, just go back to
yes,
this slide.
yes, yes,
No, I want
yes,
you to, this is important. I'm sorry I'm interrupting you. Look at
yes,
the
sir,
left
please.
eye. You see,
Yes, sir.
Adiraj, proptosis
Yes, sir.
is protrusion of the eyeball with ptosis, right?
Yes,
That
sir.
is proptosis. Here you are having protrusion of the eyeball with retraction of the left eyelid. So this is
Yes, sir.
exophthalmos.
Right, sir.
You
Right.
understand? There is retraction
My
of the
mistake, sir.
eyelid.
I
There is
understand.
exophthalmos. I don't see any proptosis. There is
Right.
bulging of the eyeball, but in addition, there is retraction of the upper eyelids, left more than right. So this is bilateral
Yes.
exophthalmos.
Right, sir. My mistake, sir. I understand. This is. I would refine it by saying that the patient is having bilateral exophthalmosis at this stage, left more than right. And while we were doing a skeletal examination, we found an additional finding which the patient had not complained. So there was a bony swelling on the tibia on both sides. Though the of about 4 to 3 centimeters in size with a height of about 0.5 centimeters. This swelling was hard, irregular, and the skin over it was and upon movement of the ankle and the knee, there was no change in the size of the swelling, suggestive that this is a bony swelling, which was non-tender and non-mobile, without any skin changes over it. Going back, we asked this patient why, since then, that how long has the swelling been there? So he said that it has been there for about 1.5 years, and did not bother him, so he did not consider it significant. We did not find any swellings in any other part of the body, and the skeletal system otherwise was within normal limits. Rest of the head general examination did not reveal any positive findings. Systemic examination was also within normal limits. Then we went to a focused neurological examination of the patient, and we found that the patient, despite being a postgraduate, has scored only 15 out of 30 in MOCA examination. We used 8.2 here, and we found that 8.2 version, and we found that he is having a severe affection in the executive domains as well as in attention and delayed recall, such that he was not able to recall even after multiple prompting. Even at the second prompt, we can see that he is not able to recall most of the things that we have asked him to recall. Then we saw his speech, and I would just like to play a couple of his videos here for understanding.
मेरा नाम मोनू है, मैं इसमें से इलाज करने आई हूँ। मेरी उम्र 25 साल है, मैं लालसोट से आई हूँ, इसमें इलाज करने।
So what I could appreciate was that the speech of the patient appears to be slurred. This patient speech is dysarthric, slurred, and there is some amount of scanning component and a slight nasal twang as well. Then we moved on to the cranial nerve examination. Visual acuity was 6/9 in both eyes. Other than that, we did not find any abnormality in the examination of the second cranial nerve. Then we assessed the extraocular movements of the patient. And while assessing the extraocular movements of the patient, we found that he had restriction of the left lateral gaze. As well as, but besides that, extraocular movements are within normal limits on all other sides. And there was bilateral gaze evoked nystagmus when he went to the extreme of his horizontal vision. But when he looked up, we also found that the patient has a vertical nystagmus with the fast component beating towards the top. This is another video, better focusing on the nystagmus part. Then
Adhiraj, you can just play the video once again for the audience so that they can clearly see. So,
yes,
and you can describe them as you want. Yes.
I'll just highlight the video again. So now we are assessing the extraocular movements. The patient is being asked to look towards the left side, and we can see that the left eye is not able to turn completely towards the left side, whereas on the right side, his movement is complete. His down gaze movement is also complete over here. And now we have asked him to look up. The right eye, we can see his right and left eye both. There's almost complete movement in the vertical plane. So in the extraocular movement, we only found that there is a restriction of the left lateral gaze, suggestive that the left lateral rectus definitely is involved. Then moving on to the diplopia examination, we did a diplopia charting of the patient, and we confirmed that in the horizontal, in the primary position and the left and the right gaze, we found that there is a maximum difference is seen in the blurred vision, blurred eye, blurred image, and the clear image in the left gaze, which decreases as we go towards the right side. Here it was completely horizontal. In the superior gaze, there was an oblique component to it as well. And in the down gaze, there was no diplopia observed by the patient. Moving on to motor examination, we found a few abnormalities here, which confirmed our primary localization that we found in the history. Bilateral lower limb was increased. It was spastic. Power was within normal limits. And reflexes were generally increased in upper limb. It was 3+ in the biceps as well as in the triceps. But in lower limb, they were exaggerated. Both knees were 4+, ankle was +3, and we had bilateral plantar extensor, confirming that there is pyramidal involvement in this patient. Sensory examination, what we found was that the patient had loss of joint position sensation up to both the knees, both the ankles, sorry, and the vibration was impaired, completely absent up to both ankles, and had an early decay of about 4 seconds at both the tibial tuberosity. And there was 70% decreased in sensation of both fine and coarser sensations up to the level of mid-thigh. Then we moved on to the coordination part of the exam, and we found that the patient has normal saccade and pursuits. No abnormality in saccade and pursuits. Again, we confirmed the finding of a vertical nystagmus. We can appreciate that the patient has some amount of vertical nystagmus here with the fast beating component towards the top. The upper limb coordination examination, such as here we are assessing for the patient finger chase also showed that there was some dyspepsia in examination in both limbs. Dysdiakinesis of dysdiakinesia was present in both hands. We can appreciate that there is the right-sided dyskinetic symptoms are more compared to the left, but it is present on the both sides. Here, while attempting again, we can appreciate that he is having coordination issues. He slows down as he comes close to the nose. Present on both sides. While examining the lower limb, again, our findings were confirmed, and we found that compared to the upper limb, both the lower limbs coordination was much severely affected. Here, no asymmetry was appreciated. While doing a heel shin test, could easily see that the patient is was unable to perform it even for a single time out of 3 attempts. Lastly, coming to the gait examination, we found that when the patient, when asked to sit up stand up from sitting position, he needed the support of both hands to stabilize himself. While getting up, he would tend to bend forward and his spine would also sway from side to side. And while making a stance, he needed to make a broad-based stance. There was no hesitancy in initiation. I just play the video here and describe. There's no hesitancy in initiation, but look, his foot placement is erratic. His cadence is slow and cautious. And here, I'll just show the turning in this video. Sorry. Yes, just play the video once again. So,
Dr. Adhiraj, I think you can be slight faster.
Yes, sir. Yes, sir.
Investigation discussion will be there also. So yes, we had in conclusion both the axial and appendicular ataxia with some nystagmus and cerebellar speech.
Yes, sir. Exactly, sir. And after examination, again, besides our initial impression, we were able to better localize what we had found. But additionally, we found another system involvement which we did not have earlier. So this skeletal system involvement in the patient. So at this point, I will discuss some of the differentials that had come to our mind. So one possibility which we had kept first was sarcoidosis, because the patient had multi-system involvement with cutaneous, skeletal, as well as orbital involvement. Neuro, the chronic indolent course also supports this. However, the characteristic features that are generally seen in neurosarcoidosis, such as the multiple cranial neuropathy and history suggestive of hypothalamic pituitary involvement, was not there. And the bony lesion was a bit uncommon in the patient. Another multi-system disorder which we considered was IgG4 for similar reasons. But again, the factors against him that the patient was younger than than the typical patients, and the cutaneous lesions were atypical in the patient. Then we kept a broad heading of orbitocranial tumors, consisting of lymphomas, meningiomas, neurofibromas, and in the same heading, because the asymmetric course and the painless progressive proptosis, as well as the neurological involvement, could explain this along with the bony lesions. However, the long history of 6 years, 3 to 5 years of neurological complaints went against this. And the last possibility we kept was granulomatosis with polyangiitis.
Yes, Dr. Adhiraj, yes. There are some questions in the chat box which many of the residents are asking. So most of them feel that it could be a neurofibromatosis 1 or cerebrotendinous xanthomas. They are considering that. Some of the
Yes, sir.
questions regarding the clinical examination, some residents are asking. Some of them are asking, is the head circumference normal? Was there any
Yes.
peripheral thickening of the nerves? Or were there these hypopigmented patches were hypoanesthetic? Or whether there was any presence of corneal hypoanesthesia? So, and whether is there any clinical enlargement of the lacrimal glands? So, whether any thickening of nerves, lacrimal gland enlargement, any hypoaesthetic scars, I mean, pigmented scars that some of the people are asking.
Yes, sir. So I'll answer these questions. Firstly, like I said, the only sensory abnormalities that we found were in the lower limb. So the patches were not hypoaesthetic. He had preserved sensations over there. The nerves were not thickened. There was no nerve palpable. And I believe, what else?
Lacrimal gland enlargement.
Lacrimal gland enlargement was not present. And the head circumference was normal. Yeah, if I believe what we measured to the patient, about 51 centimeter he had a sorry, 54 centimeter head circumference he had for the patient.
Yes, thank you. And one more thing that you mentioned, like this is an adult male. I can see this patient has, this is an adult male, right?
Yes, sir. He's 26 years old at present.
So they're like the lack of secondary sexual characters. Is it present or
yes,
absent?
sir. Yes, sir. I'll elaborate on that. Actually, we also felt when looking at him that he has some lack of sexual character because of sparse facial hair. But when we examined his axillary hair, as well as his pubic hair, they were well formed. And according to Tanner staging, he had Tanner stage 4. His external genitalia was well formed. So yes, we did not find any abnormality on that side, sir.
Yes, these were the doubts that people were having. Thank you.
Dr. Atiraj, if I may just, make an observation, a
Yes,
brilliantly presented case. I think
you,
it teached all of us, all our intelligences, and it was presented in a very good manner, excellent manner. One observation I had was it's a multi-system disease. There's obviously skeletal lesions. There are skin lesions which look like seborrheic dermatitis. And you also have multiple sites of neuraxis involvement. Did you consider Langerhans cells histiocytosis? I think Professor Lal, at the history level itself, mentioned it. Did you consider this as a possibility? Because you can get all these lesions in that. Just a thought.
Sir, we did not actually, honestly speaking, when we saw the patient on the history point of view, we did not consider any such findings. Even when we saw the bony findings, because it is a rare disease, we did not consider it at that point of time. So yes, no, sir, it did not come to our mind initially, sir.
I think it could be a likely differential diagnosis, which we must consider.
Yes, sir.
Yes, sir, rightly said. Yes, sir, rightly said, because the differentials considered, even with the multi-system, there are more negative points. Except the sarcoid, when you don't have the X-ray, you can keep it. IgG4 is also a rare disease and to be progressed for the 4, 5, 6 years like this. So one can consider on the basis of multiple systemic disorder with skin, bone, after the examination, bone and the neuraxis involvement. Yes, sir, rightly said. So I think now
yes, sir, I have reached the end of my presentation, sir, and I hand over back to you, sir.
Now I invite Dr. Vipul to discuss the investigation part of this patient.
Good evening, sir. Good evening to all the panelists and all the attendees. Now I'll be presenting the second part of the presentation. That is the investigational part. So just a second. Yeah. So we went on with the biochemical and the hormonal profile of the patient, and we got in the hematology workup, we found that the patient is having a microcytic anemia. Only one cell line was reduced. He was having a hemoglobin of 10, and for finding the cause of that, we got a serum ferritin done, which came out to be 23. So we termed it as iron deficiency anemia. The CRP and ESR of the patient, the CRP was positive and ESR was raised, which signified that the patient is having some inflammatory state in the body. The renal function and the liver function tests were normal, so they did not define any systemic dysfunction of those organs. The calcium level, the vitamin D level, and the ACE levels, with the point of view of sarcoidosis, we got them down and came out to be normal. Also, the hormonal profile of the patient, including the thyroid function test and the cortisol levels, were normal, which indicated that the patient had an intact hypothalamic pituitary axis. And lastly, the autoimmune panel consisting of the ANA, dsDNA, and the immune 17 panel was done, which also came out to be negative, and so ruling out some autoimmune condition. Then we went on with the imaging of the brain. The MRI of the brain, in the first image, we can see that there is T2 flare hyperintensity present symmetrically in the bilateral dentate nuclei and in the dorsal part of the pons, involving the middle cerebral peduncles also. And in the besides image, we can see that this is a T1 image, and we can see that these lesions are non-enhancing. Uh, in a different cut, at the orbital cut, we can see that in the first image that there are orbital masses bilaterally, which are of mixed T2 hypo and hyper intensity, and these lesions are more on the left side. And in the besides image, we can see that they are taking heterogeneous contrast enhancement also, and we can see that the optic nerve is traversing through this lesion, and more or less the size of the optic nerve is still intact. So, and also we can see in the coronal cuts that in the right side also the optic nerve is preserved. This is the coronal T2 star image. And sorry. In this image, we can see the muscles in the orbit. The muscles are more or less pushed on the side. In the left orbit, we can see that the mass is very large and the muscles have been thinned and pushed to the sides. All the muscles, although are intact, they are not involved. Then we saw the sagittal cut. In the sagittal cut, we saw for the hypothalamic pituitary area, and there we saw that the pituitary stalk is normally enhancing on the contrast image, and the size of the pituitary stalk is 2.19 which is within normal limits. Then the supratentorial cuts showed that there is no flare hyperintensity cortical or subcortical in the supratentorial regions. And this T1 image shows that the patient is having age disproportionate atrophy according to his age of 26 years. Then we also noted that the patient is having calvarial lesions which are of mixed T2 intensity, and these lesions are having a heterogeneous enhancement on the contrast images, and they are expanding the diploic spaces also. Then we got a MRI of the cord done, and in this we can see that the cord is having patchy myelitis right from the brainstem to the cervical cord to the upper thoracic cord. Although the middle and the lower thoracic cord is still preserved, and in the axial sections also we can see that there are patchy hyperintensities present. Then we got a radiography of the bones done, and this skull radiography is showing that the patient is having heterogeneous lesions throughout the skull. The lesions are of mixed intensity, so these lesions are seem to be lytic in nature, and these lesions they seem to be sclerotic in character. Then the long bone radiography showed that there are symmetrical lesions in bilateral tibia, and these lesions are also of mixed lytic and sclerotic pathology with the prominent periosteal reaction causing cortical thickening. uh, the long bone involvement was also present in the bilateral proximal tibia and the distal femur, and these were also symmetrically involved. So, on the basis of these X-ray findings of mixed lighting and sclerotic bone lesions, we temporarily pause for the differential diagnosis just for the X-ray lesions. They from in the on the malignant side, they could be metastasis. Usually, the breast cancer causes metastasis of the lytic type, and but both breast and lung cancer can cause mixed type of lesions also. And in the benign spectrum, we can take a possibility of histiocytic disorders, which can cause both lytic and sclerotic type of changes. And Paget's disease would be a differential. It is mainly a osteoclastic disorder, which causes abnormal bone metabolism. And Third differential would be a fibrous dysplasia. In fibrous dysplasia, the thing that is against is there would be a medullary expansion of the bone because but the cortex are still thin. There is no periosteal reaction, which is against our case. So later on, we got a CECT of the chest done, and in the CECT, we saw that there are multiple cystic spaces which are present in the bilateral lungs. And these cystic spaces are also associated with centrilobular reticulonodular shadows, and these kind of findings can be present either in pulmonary histiocytosis, and also we can find these cystic spaces in leiomyomatosis, but that is a disorder of young women of childbearing age, and these nodular opacities are not present in leiomyomatosis. And then we can keep a possibility of sarcoidosis and tuberculosis. For that, we were not able to see any lymph nodes, both calcified and non-calcified, in the mediastinal window. And also, these nodular opacities can be present in both this TB and sarcoid, but the cystic changes are not characteristic of them. Then we got a PET scan of the patient done, in which we found metabolically active lesions, which were present in symmetrically in the long bones, as we saw in the radiographs, both in the distal tibia and in the proximal femur, and also in the skull, which is not visible in this image. And also, there were metabolically active soft tissue masses in the bilateral orbit. Sorry, not the optic nerves, in the bilateral orbits. So, on the basis of these investigations, the differentials that we got ruled out are: first is sarcoidosis because of the normal serum calcium and the vitamin D levels and the ACE levels, and with the absence of any mediastinal lymph nodes on CECT chest, and the mixed character bone lesions. IgG4 related disease was also ruled out because of absence of any pachymeningeal thickening on the brain MRI, and due to the presence of bony lesions, which are usually not present in the IgG4 disease. Then the third possibility, cerebrotendinous xanthomatosis, was kept because the patient had this progressive ataxia, spasticity in the lower limbs, and bilateral symmetric dentate hyperintensity. All these things are present in CTX. But in our patient, we could not find any tendon xanthomas, both at the typical and the atypical sites. And also in CTX, there are no bony lesions found. So after that, the possibility of GPA, which was kept after the examination, that was also ruled out because of the absence of any sinonasal disease, which is very common in GPA, and due to the absence of pulmonary lesions, which are typical pulmonary lesions of the GPA, were not present, and also the vasculitic panel was negative. Then the Graves or orbitopathy was also ruled out because the patient had a normal thyroid profile, and in the PET scan, the thyroid did not take any uptake, and the bone lesions are also not present in Graves or orbitopathy. So after ruling out all these differentials, the differentials with which we are left now, in view of the 5-year-long history with the progressive course, multisystemic involvement, with the involvement of the skin, the bones, the nervous system, in the nervous system, the orbit, the brainstem, the dentate, and the cord, we are lastly left with the possibility of two disorders. One is histiocytosis, and secondly, in with the bleak possibility of some indolent lymphoma due to the longer course. Possibility of a marginal zone, follicular type, or mild lymphoma may be present. Just to confirm the diagnosis, we went on with the tissue sampling, and we
Just
got
Dr.
the skin.
Vipul, just to
Yes,
interrupt
sir.
you, just
Yes, sir.
in our participant groups, our participants have also at this level they suspected LCH.
Yes, sir.
Okay, continue.
So, for the tissue diagnosis, we took a biopsy of the skin from the forehead skin lesions, and this is a H&E stain film with the resolution of 100x, and we can see that this upper part is the epidermis, and below the epidermis we can see an infiltrate of large mononuclear cells, though the cytoplasm is not, the cell borders are not individually visible because all of them have been merged. But we can see these nuclei, these basophilic nuclei. These nuclei are folded upon themselves, and that's why we are able to see this groove in these nuclei. And this is giving them a typical coffee bean or kidney shaped appearance. So this appearance is characteristic of histiocytes. And also the another cell population that we are able to see in this image is these dense basophilic cells with scant cytoplasm. So these are the lymphocytes. So overall, we are able to see that the skin had a lymphohistiocytic infiltrate and present predominantly in the dermis. So these findings weigh much more towards the possibility of histiocytosis, and more or less now we are confirmed that the patient is a case of histiocytosis. Now we need to classify that which type of histiocytosis is this case. So in 2016, there was a revised classification of the histiocytic disorders in which there were 5 groups were made. The first one was the L group, and the second was the C group, cutaneous. R group was Rosai-Dorfman disease group, and M was the malignant group, and H was the HLH group. In our case, we are mainly concerned with the first group, that is the L group, which includes Langerhans cell histiocytosis, intermediate cell histiocytosis, Erdheim-Chester disease, and a mixed LCH-ECD overlap. So now we will see what features do our patient have, and they match with which subtype. So these are the patient findings in our patient, and these are the the disorders in which they are supported. So a young age of presentation is mainly highly suggestive of the Langerhans histiocytosis. ECD mainly presents in a later age group, like typically after 40 or 50. So this is in favor of LCH. The scalp inflammatory lesions are also more in favor of LCH. The skull and the long bone lesions, which are of mixed sclerotic and lytic type, they are more in the favor of Erdheim-Chester disease. The orbital disease that we found in our case, which was prominent, that is also more in favor of ECD. And the xanthelasma, the images shown by Dr. Adhiraj, there were prominent periorbital papules present. So those xanthelasma are also more prominent in the ECD. And the diffuse cerebral atrophy, the symmetric dentate lesions, and they can be present in both. And the pulmonary cystic disease, that is of course more favorable of pulmonary Langerhans cell histiocytosis. and the absence of retroperitoneal fibrosis and cardiovascular infiltration, which we saw in the PET scan. There was no cardiovascular uptake, and there was no encasement of the aorta or the kidneys. So this is also in favor of Langerhans histiocytosis. Overall, we can see that the patient is having mixed features of both LCH and ECD. So we think that this patient may be an overlap case. So the IHC markers which would differentiate both of these disorders are CD1A, CD207, that is Langerhans, and S100. They would be positive in LCH, and CD163 would be positive in ECD. So we did the same. We went on with the immunohistochemistry at our own institute itself, and for the subtyping. So this image is a CD207 immunostain at 100x resolution, and we can see that there is an intense membranous and also cytoplasmic staining. So from this immunostain, we were confirmed with the diagnosis that the patient is surely having LHC. And although we could not get CD163 stain done, but with the clinical features, still we are keeping the possibility that the patient is having a final diagnosis of a histiocytic disorder of the L group with the subtype of LCH ECD overlap. So this is how we made the final diagnosis of the patient. And now discussing the treatment part. This is a international consensus recommendation report on for diagnosis and treatment of Langerhans histiocytosis in adults. It was published in 2022, and it was advised in this consensus statement that a biopsy of the lesional tissue should be done in all the cases. And even if the histopath is equivocal, but the clinical features are clinical and radiological features are very suggestive, then also a diagnosis should be considered strongly. Then a full body FDG PET, MRI of the brain, HRCT of the chest, all these are recommended, and we have got all of them done. And this was a article published in 2011 regarding the incidence and the radiological patterns of the central nervous system Langerhans histiocytosis. Although it was in the pediatric population, we could not find this much sample size in adult population. So in this paper also, it was found that the most common MRI finding was a symmetric hyperintensity in the dentate and the globus pallidus, which is present in our case also. And the second most common finding in this series in this study was absence of the pituitary bright spot. In our case, this pituitary bright spot was still present, so this was an atypical finding in our case. And the stalk thickening and enhancement can also be found, but as we saw in the previous images, there was no stalk thickening. The size was within the normal limit of the pituitary stalk. And the third finding which found in this study was cerebellar, cerebral, and callosal white matter hyperintensities, which were again not present in our case. So on the treatment part, our case was of multi-system LCH. So in our case, the therapy would be particularly based on cladribine, cytarabine, or vinblastine, along with the prednisolone. And we would have to get a repeat FDG PET done after 2 to 3 months of initiating the therapy to see the response of the therapy. Regarding the prognosis of the patient, the CNS involvement which has already occurred, it portends a poorer prognosis, and the patient will have an increased risk of malignancies, both of the myeloid and the lymphoid series, and also solid organ malignancies like lung and the thyroid. So, thank you.
Dr. Vipul,
Yes,
these patients usually present with the diabetes insipidus also. And
yes,
in
sir.
your case, the pituitary was not involved. So I think
Yes,
that
sir.
is the unusual feature for LCH and ED. Both.
Yes, sir. Yes, sir. These patients have a very common presentation with diabetes insipidus also, and our patient did not have both the symptoms and also no involvement in the imaging also of the HPA area. Yes.
Thank
Dr.
you.
Karthik, I
That's a very
think
good
now the
presentation.
case may be discussed.
Yes, sir.
Excellent presentation, sir, by both the residents. A very well worked up case. Many congratulations on this case, sir.
Thank you, sir.
Thank you, sir.
Any more comments? Any
Dr. Lal,
comments?
sir?
No, I just want to compliment both the residents. This is not excellent presentation. This is state of the art presentation. I'll go one step ahead. This is beyond excellence. This is state of the art. In any forum in the world, everyone will stand up and applaud. I've really enjoyed both the presentations. I congratulate both the residents and, of course, the grooming team in SMS Jaipur for doing such a fabulous job. It is easily one of the best presentations I have seen in my life. Congratulations and thank you so much for enlightening us. But in a way, I'm lucky I got the diagnosis right. ये तो मानना पड़ेगा कि I thought of this diagnosis bang on. I
Yes,
just
sir.
thought of
You
it.
thought in the early part also, sir.
And it turned out to be histiocytosis. I do not know why I thought of that. ये मेरे को समझ नहीं आ रहा. But I smelt a rat. I said ये neurofibromatosis नहीं हो सकता क्योंकि historically there are no cutaneous neurofibromas, and to
Yes,
have
sir.
this kind of a disseminated neurofibromatosis without cutaneous neurofibromas is odd. Although in an individual case it can occur, but यहाँ पे it was dissemination all along. So I
And
thought
sir,
of
the good part is that the histopathology was done in our institute, and
I
even
heard
till
that. I
the
heard that
Wednesday, sir,
IHC staining was done, your PET scan was done, everything. That's why I'm saying it's a state of the art presentation.
So
It's
the
a
bone
state of
till
the art
the
presentation.
Wednesday, sir,
bone
we did
biopsy.
not get even the films of histopathology, and we were still in the doubt that what will be in the histopathology, and we strongly suspected that it must be, although rare in the adult patients, and we suspected LCS that.
Good, very good, excellent.
Sir,
And
still the
Aditi,
bone
Aditi
biopsy.
and company, congratulations. Adiraj, you both have done a fantastic job. And of course, the discussion of radiology and others by Dr. Fogart was outstanding. It was just the
So, Dr.
icing on the cake.
Bhavna,
Thank you, sir.
Thank you, sir.
Sir, many thanks to all of you for giving us the opportunity to present the case.
अब भावना मेरे को तो ना जयपुर आते डर लग रहा है. इतनी हाई प्रेजेंटेशन है, इतना हाई लेवल है.
सर आपके सामने कुछ नहीं है सर, हम तो
नहीं. अब तो I'll get my proper, मैं अपनी शील्ड लेके आऊंगा. It's a beautiful presentation. Astha, are you online or are you offline?
No, sir, I am online, sir. I think
Ah.
all the questions have been beautifully asked, sir. The audience participation has been so wonderful.
yes, of
More
course.
than 20-30 messages in the chat box. And I think all the questions were very well and very nicely answered. We had many things to learn, ma'am. Thank you, sir and ma'am, for this wonderful presentation.
Beautiful presentation. Thank you once again. Thank you.
Thank you, sir.
Thank you, sir.
thank you all, sir.
Thank you,
Bye.
sir. Thank you.
Bye.
Thank you. Thank you,
Good
ma'am.
night, sir.
Sujit,
This was a
bye,
very
Karthik.
enlightening presentation.
And once
For
again,
all
really
of us.
grateful. Bye.
And sir, it
Thanks,
was
ma'am.
a pleasure to see you.
Thank you. Namaskar.
Namaste, sir.
Namaskar, sir.
Thank you, sir. Thank
Thank
you
you,
all
sir.
for being
Thank you,
there.
sir.
Thank you all the panelists. Thank you all the presentations and congratulations, sir. And thank you all the participants who have actually participating in the group chats. I thank Professor Lal, Professor Priya Kumar, Professor Bhavna Sharma for their excellent contribution. The three excellent presenters, Dr. Adhiraj, Dr. Vipul, Dr. Aditi, for a clear and concise presentation. Our IN Neuro-Ophthalmology Subsection Chairperson, Professor Sujit Kumar, for his moderation. Thank you all, sir. And special
And thank you,
to
Dr.
the
Karthik,
IN
once
team
again
also.
for your kind support to execute this webinar.
Thank you, sir.
Thank you, sir.
We'll have a meeting again, sir.
Yes,
Thank you.
sir.
Thank you, Sujit sir.
Okay.
Thank you, sir. Thank you,
Bye,
ma'am.
everyone.
Thank you
Bye.
all. Good night.
Bye, Karthik.
Bye, ma'am. Bye.
Bye.